Hello, good evening, everyone. I am Mansi Gupta, PhD student in the Department of Mechanical Engineering at IIT Delhi. Welcome to the Public Systems Planning and Optimization Symposium. In today's webinar, we have Professor Varun Ramamohan from Indian Institute of Technology, Delhi, presenting on the paper titled A Simulation Model of Breast Cancer Incidence, Progression, Diagnosis, and Survival in India. Dr. Varun Ramamohan is an assistant professor in the Production and Industrial Engineering Group within the Department of Mechanical Engineering at IIT Delhi. He did his BTech in Production and Industrial Engineering from NIT Trichy and PhD from the School of Industrial Engineering, Purdue University. Before joining IIT Delhi, he worked at a non-profit research institute in US, the Research Triangle Institute International. His research interests lie in the areas of probabilistic modeling, simulation, optimization, with applications in healthcare, biomedical systems engineering, and health economics. Over to you, Professor Ramamohan.
Yeah, thank you for that introduction, Mansi. I have presentation rights, right? I can share my screen.
Yes, sir, you should be able to.
Okay, so let me just try that. Okay, yeah. So is my screen visible?
Yes, sir.
So just give me 1 minute. Just want to make sure. Just share my entire screen. It's easier. All right. So thank you for the opportunity. Always glad to talk about work in health. So yeah, so I'll be talking about just trying to figure out this annotation tool. So I'll be talking about some work that we did about a couple of years ago, although we're still continuing to use this to sort of continue to work on not just this topic, but to use what we've developed a couple of years back for various other studies. So what I'm going to talk about today is the development of a simulation model of breast cancer incidence, progression, diagnosis, and survival in the Indian context, right? So this was actually developed. This work actually came out of a BTP, right? So out of a BTech project for those of us who are not from IIT. So worked with two talented undergraduate students who did an excellent job in this work. It resulted in one conference publication, which is what I'm going to present today. And of course, we're working on an extension of what I'm going to present today for a journal as well. And in fact, we're going to have a couple of students take this up as another BTP, where they're going to use this model and use this for other studies actually, right? So I'll talk about that in a minute. So the reason I'm mentioning this is because the work that I do with my PhD students, I thought it would be better that they presented themselves. And given that this is work with BTech students, even though one of my PhD students was involved in this work, I thought it would be better for me to present this because they are not around to present it right now. So I'll talk about why we did this and what we're going to do with this and provide more details. But let me just sort of talk about the team. So Saumya and Chandan, as you can see here, are the BTech students. Soham is a PhD student who helped me with the literature review and with the writing of the article. So did Dr. Shaurya, who is also an assistant professor and another convener of the Public Systems Planning and Optimization Symposium. And of course, when we develop any model of, in general, anything, almost anything to do with healthcare, right? Especially when we're developing a model of a disease progression, it's always a good idea to work with somebody from the medical field. So we collaborated with oncologist Dr. Atul Batra in the Department of Medical Oncology at AIIMS New Delhi. So he specializes in breast cancer, and he basically advised us on the model development. He provided us with some costs and so on, which I'll talk about later. And in general, made sure that we were not making assumptions that were too unrealistic, right? Okay. So slide, yeah. So this is a big part of my work involves developing mathematical and computational models of public health delivery. So that falls right under the public systems, under the public systems panel. So one of the main things that I'm sort of focusing on as part of my work is to establish the computational is to establish a set of computational tools that can be used to analyze healthcare delivery, right? From an operational standpoint, of course, because we're OR people, and what we're interested in, of course, is in general operational things. And so the idea is to develop tools that can be used for analyzing the delivery of healthcare, right, in the Indian context. And of course, public health delivery is sort of the obvious focus, of course, in a country like India. For those of you who are not familiar with what the public health system sort of in India looks like, let me give you a very quick sort of overview. So on paper, we actually have a pretty good system. So, for example, we have this network of PHCs, CHCs, and DX, and not just in paper, but to some extent, they're doing actually a reasonable job. But what we see is actually that there is a significant sort of variance in the quality of care that is delivered through this sort of these foundational units of public health delivery in India. Right? So you have PHCs, primary health centers, you have community health centers, which provide primary and secondary care, and then you have district hospitals, of course. Right? So where you go for slightly more specialized care and for sort of more medically sort of serious cases, right? Okay. So what we have focused on is in developing simulation models, right, of these foundational units of public health delivery in India. There are around 35,000 PHCs in India. And the government has a vision to increase this actually significantly, not just to increase the number, but also to upgrade them. So that is sort of ongoing. Community health centers, there are fewer for obvious reasons, right? So PHCs are basically small clinics which are staffed by 1 or 2 doctors, few nurses, and so on. They offer primary care primarily and some immunization outreach activities. CHCs are 30-bedded hospitals. They're supposed to be 30-bedded hospitals, although what we've found is it actually varies, right? So some CHCs work at their mandated sort of capacity, whereas some a lot of PHCs that we've seen work below their mandated capacity. Even though they're supposed to be 30-bedded hospitals, a lot of them have maybe only like a few beds, right? 5-6 beds or so. And although they're supposed to have specialists visiting them to sort of offer some specialist care, such as, for example, gynecologists, etc., obstetricians and gynecologists, ophthalmologists, internal medicine specialists, and so on, we find that that also varies. District hospitals, for the most, and so as a result of this sort of inconsistency in the quality of care that is offered at these facilities, as well as the staffing and the operational level at these primary and secondary care facilities, we find that the bulk of the public healthcare delivery actually falls to the hospitals, right? And that is one of the issues. So there isn't. So because of that, a lot of people often just go to district hospitals, right? So that is one aspect. So I just want to sort of give a quick overview of public health delivery. So we have been developing simulation models of these PHCs, and we've been looking at, okay, what happens if they actually functioned at their full capacity, right? And what happened if even though only 30% of India actually seeks care at public healthcare facilities, what we wanted to see is, okay, what happens if 50% of people seek care at public health facilities? What happens if 60%, 70% seek care at public health facilities? Right? How does operationally, how will the PHCs, CHCs, etc. cope with this sort of that sort of patient flow, right? So that is something. So that is something that we've sort of explored through our simulation models. More than that, of course, is once you develop this sort of these computational tools required to analyze a public healthcare delivery, you can actually use them to do multiple things, right? So one of the things that we've done is we've shown how, let's say, for example, you developed a simulation of a set of PHCs, for example, and a set of CHCs, and some part of DH operations as well. What we have seen actually is that you can put them together to actually model the delivery of public healthcare in in a given region, right? So, for example, in a district. So, one of the districts that we have worked with is, for example, the Gurugram district. That has around 10 to 11 PHCs. It has about 3 CHCs, and of course, it has one district hospital. So, we've actually developed what we call as a multi-tier public healthcare network simulation, and we've used that to actually simulate how COVID care can be delivered, right? So, how can you plan for capacity planning and facility location during a pandemic using such a multi-tier public healthcare facility network in the district? And the general idea of doing this is that what we've done is we've used what is called as a generic simulation modeling principle here, which essentially means that you develop a model. Is that when there are multiple instances of a facility that are operating, there are bound to be differences in the organization of the facility, in the way care is delivered, the staff levels, and so on, right? So what we did is by visiting like 10 to 15 PHCs, for example, we have a sense of, okay, what are the different configurations of PHCs that are operating? Of course, it's not really a statistically representative sample of, for example, the 30,000 PHCs that exist outside. Across the entire country, we've essentially focused our visits on one or two districts. And but still we get some sense. And when you compare that to, for example, the operational guidelines that exist for these PHCs, using that you get a sense of, okay, what a PHC should look like, right? So using both data collected from our visits as well as the operational guidelines that are out there. So using this, you can develop actually representative models of the different configurations of these facilities actually, right? And these are called as generic simulation models. And the idea being that in order to represent a specific instance for PHC, you can take this generic model and then quickly modify it and then then actually use that, right, to actually model the operations of this PLC. So the idea is once you develop this sort of generic simulation model, and then you can sort of create instances of these PHCs, you can put them together to model public healthcare delivery in a given district. And then there are many other things that you can do. So, for example, we've actually developed patient diversion mechanisms between these PHCs, between a network of PHCs, for example, using real-time delay and length of stay prediction. So that is work that I'm doing with other PhD students. We've also looked at many other things, right? So we've also looked at, for example, HCV transmission dynamics. So that is the hepatitis C virus. So it's a chronic disease similar to HIV in some sense, but actually a little more slow moving. And we are using that agent-based model of HCV transmission dynamics to evaluate the cost effectiveness of HCV treatments, because most of the existing models that are out there, even in the Indian context, actually only use what we call models that don't take transmission dynamics into account. So one of the things that we want to see is, okay, how does the cost effectiveness of HCV treatments change when you actually take the transmission dynamics into account? Other than this, there are many other smaller problems that we've worked on. I wouldn't call them smaller problems, but let's say, for example, that they're slightly more specialized problems. You can say they're specific to maybe like a particular disease or a particular operational unit and that sort of thing. So, like kidney and liver transplantation systems, we looked at the department at wait time prediction for patients who are waitlisted for neurosurgery in AIMS. We've also looked at vaccine distribution logistics for multi-tier cold chain networks. So again, some of this work is done with undergrads, but the first the first bits of work that I talked about, the PHC, CHC models, the referral mechanisms, the HCV model, and so on. All these things actually we work with PhD students. Finally, what I'm going to talk about today is about the development of a simulation model of breast cancer incidence, progression, diagnosis, and survival in India. So one thing I want to mention here and is even though we work on problems that are sort of very specific to the Indian context, so we always have an eye on, okay, how can this work be generalized beyond India, right? So how does it contribute not just to, of course, to public healthcare delivery in India? How does it inform policy? How can it, serve? How can it do that? But also, we also want to look at, okay, how does it contribute to the operations research, to the industrial engineering literature at large, right? So that is also something that we always have an eye on. And so with every project that we do, we try to see, okay, is there something methodological also that we can do? So that is something that we look at. So even though if you look at, for example, today's project, which is about the development of a simulation model for breast cancer incidence, progression, diagnosis, and survival in India, what we found is because the availability of data in the Indian context it's somewhat unpredictable, you can say, right? So there are, for some things there is excellent data, for some other things there isn't that great data. So the kind of data availability that we have, that throws up challenges, methodological challenges, right? In the sense that, okay, the question is, okay, given this data availability situation, how can you develop a methodology? How can you use this existing methodology with some modifications to uh, actually develop a good model of the system, right? Can actually inform uh, that can inform operational protocols or policy in some way, right? So that's something that I'm going to talk about today. So that's why one of the things that's why what I want to talk about today is the development of this model of breast cancer incidence, progression, diagnosis, and survival. And I'll talk about, okay, how what methodological things that we what methodological things that we did in order to handle the data availability situation that was specific to the Indian context, right? And how that can serve as a template, for example, for developing similar models in other countries with similar data availability contexts. Okay, so this initial model was published in it's not an initial model. The model is it's sort of finalized. So, but this is sort of a paper that we published in the Winter Simulation Conference, where we talked about the development of the model, and primarily we talked about, okay, this is the way that we developed it. These are the methodological sort of changes that we've done to the way these types of simulation models are normally developed, uh, and uh, and that the idea being that, okay, this has uh, applicability to other contexts as well, which has a data availability situation that is similar to this, right? So that's what I want to talk about today. So yeah, so why did we focus on this problem? Of course, I think breast cancer, of course, is one of the most it has the highest incidence rates among cancers for women. Interestingly, in India, if you look at the incidence of breast cancer among men is actually significantly higher. It's still low as a proportion of the total number of breast cancers that are incident in India. But the incidence of breast cancer among men is actually significantly higher in India than it is in other countries. So this is actually true for a couple of other things as well, a couple of other types of cancer as well. But anyway, this is just something that I wanted to mention, right? So even though it's primarily, of course, an issue that people think of as being relevant for women, it is also something that is especially in the Indian context, it is something that we find that is of significant concern for men as well. Although for men, primarily colorectal cancer and lung cancer are the more and prostate cancer, of course, are the more commonly incident ones. Anyhow, so it's a significant problem, and the important thing to note here is that breast cancer survival in India is actually significantly lower than it is in other countries. So the average survival, if you look at the most recent paper, about 2018 or so, average survival in India is on the order of 66%, right? 5-year survival. But if you compare that to, for example, a lot of other countries, it's around the order of 89 to 90%, actually, the 5-year survival, the median survival. So now in India also there's a wide variance, by the way. So the average survival is 89 to 66% with a big variance, around 18% variance actually. But what you find is that if you look at urban areas with or among people of higher socioeconomic status, it actually approaches what you see in the West. right? It approaches around 89-90%. So the big issue with survival here is, of course, is the inequities in access, right? So it's not on the slide, but I just wanted to mention it. And the big reason for that is because, of course, the majority of incident breast cancers in India are diagnosed in the advanced stages, right? And you can see that from the numbers here. Okay, and one common thing I want to mention here about uh, the incidence of cancer in India, which I think which a lot of people know, but unfortunately, so a lot of people who are working in this area know, is that the incidence of cancer is actually much higher in urban areas than it is in rural areas. The reasons for that are not entirely clear yet. There are some epidemiological factors, and there are also factors around awareness and sort of detection and all of that. But still, it could be one or more of those reasons. Anyway. So, of course, there are two possibilities, right? If you want to detect breast cancer in early stages, first is is to educate people about sort of the symptoms, about self-screening and so on, which is then that becomes early diagnosis based on symptoms, and the other is to actually conduct screening programs. So the question then becomes, okay, what is the optimal interval to screen? Is just to screen people, right, for breast cancer, and of course, especially women. So to answer that question, right? So the answer for that question is not so straightforward, right? So for any screening program, one has to take into account the potential benefits in terms of health benefits, and also, of course, the economic impact as well, right? So because if you want to screen every person, every woman, every year, for example, right? Every year, that is a huge economic undertaking. And in India, because of issues around access to healthcare, any such screening program typically will have to be a highly subsidized program, right? So it will have to be primarily be done by the government in some sense. Yeah, so and because of that, the cost will have to be in the end borne by the taxpayer. So one has to evaluate what is the optimal screening interval based on this trade-off between, okay, how often should you screen? The more often you screen, of course, the better it is. And the other question is, of course, what is the sort of economic impact as well of screening very often, right? So we have to find that optimal screening interval. So this is a common operations research application, right? So for cancers in general, so this has been done for colorectal cancer, it has been done for breast cancer, of course, it has been done for lung cancer, a lot of different things, especially in the Western and the OECD country context. But in the Indian context, very few studies actually exist of this type. And there is evidence to show that based on pilot programs, breast and oral cancer screening studies that have been done in Kerala and in West Bengal, that have shown that, yeah, it is possible to do this. Door-to-door screening studies actually that have been done, and it has been able to do this in what they call it as a cost-effective program, but that is not a formal assessment of cost-effectiveness, right? So this is what we want to do as part of the study. So in order to do a formal cost-effectiveness assessment of what is the optimal screening interval, you first need to have a model. You need to have a model of the incidence of cancer. You need to have a model of the progression of breast cancer, and of course diagnosis and survival. So and that's what we try to do. So before you have, and this is true for any kind of cost-effectiveness analysis that hopes to inform policy, right? So even in the West, in the OECD countries as well. If you want to inform health policy around, for example, reimbursement of treatment by some public health system, or for the institution of some sort of a public health policy such as this, typically some sort of modeling study is done that is used to inform policy, right? So in the Indian context, it's still evolving in some sense, the whole health economics approach to informing policy. And this is one step forward. So one of the things that we wanted to do was to create a simulation model of breast cancer incidence, progression, diagnosis, and survival that can be used not only to figure out what is the optimal screening interval for patients, but also to determine, but also that can be used for actually, for example, evaluating treatments, diagnostic interventions. So if tomorrow, for example, somebody comes up with a better screening, a better diagnosis technique, but it is significantly more expensive, right, than the existing diagnosis technique. So the question then becomes, actually, is it worth paying for? And this is a sort of decision that is made routinely when actually deciding whether to reimburse health programs or not, right? So this is the overall context that I want to sort of establish before we actually talk about the model itself. I think I've already spent like half an hour talking about this, so I'm not going to spend too much more time talking about the about previous work. I'll move on to the model itself. But the main thing to state here, as far as previous work is concerned, is that two things, right? So there has been actually one model that has been developed for the Indian context. That was done by, I think, a group of researchers in Netherlands, right? In the Netherlands. And the interesting thing there is they used a model of disease progression that was actually developed for, it's called as a MISCAN model that was developed for the West. Okay, and although they did some calibration uh, to Indian data as well, uh, but uh, but in the end, I think it's a model that is sort of developed for the West using their transmission probabilities and so on, right? So that is one basic issue. Second thing is what we noticed is that even that particular that model is a Markov model, right? So the basic issue with the Markov model, of course, is that even though they are used widely in cost effectiveness analyses for actually modeling disease progression, the issue with Markov models, of course, is that they essentially meet the assumption of the memoryless property, right? Which means that the amount of time that you've spent in a particular disease stage, it does not influence when you're actually going to transition to another disease stage, right? So the issue, this modeling assumption may be appropriate for certain diseases, but definitely not appropriate for all diseases, especially when you have data that actually describes the survival of patients with cancer, and very often that is not an exponential model, right? So that is where I think that is another sort of drawback of the existing work that is out there uh, for actually breast cancer disease simulation, right? So, and this is we are not the first to actually say this or to even sort of use to use alternate methods of actually modeling disease progression for cancer. I've done this before myself for lung cancer. In other studies, there have been existing models that have been developed for breast cancer actually, which again do not make this assumption, this Markovian assumption regarding disease progression. Okay, and we also don't do that. So the three key sort of research contributions that we have are as follows. First, of course, we did risk factor based incidence, which essentially means that we did not look only at what is called as age adjusted incidence, which is what is done most commonly. In other words, you basically model the probability of somebody developing breast cancer as a function not only of age, but we also looked at a few other risk factors that have been established in the Indian context, more specifically actually in the New Delhi context. I'll explain that in a minute. Similarly, we also developed a new method using Indian data to actually estimate the annual probability of diagnosis in each stage, right? For methods other than screening. So in other words, basically, establishing the probability of symptomatic diagnosis in each stage is also different from what has been done before. So we use a combination of data from the literature as well as sort of a small Monte Carlo simulation, so sort of a simulation within a simulation in order to estimate this. Okay, and finally, the one key contribution that I would say is there is limited data around survival of breast cancer patients in the Indian context. What we have done is we've used that limited data to generate personalized patient-specific survival curves actually. So based on certain relevant patient characteristics, we can actually we generate survival curves that are specific to those patients' clinically relevant characteristics. Okay. Yeah, so what we do, of course, the first thing to do is to actually model incidence. So once the incidence of breast cancer, so we develop a simulation. It is initialized with around 100,000 people, or 1 lakh people, and then the first thing is to do is to figure out actually, okay, who gets cancer in each time step. So we have annual time steps in the model, and then what we do is to figure out, okay, once they've developed cancer, a certain set of people have developed cancer based on certain risk factor characteristics. We have to model the progression of the tumor, right? So how do they actually move from one stage to another stage? then we need to figure out, okay, when are they going to get diagnosed, right? Once we figure out, okay, when they're going to get diagnosed, we need to figure out, okay, what is the survival look like, right? So these are the things that we need to look at. So why is, again, if we know how the tumor is going to progress, why do we need to model diagnosis survival separately? So that's a sort of a natural question that arises in this case. We'll answer that. Of course, it's because once a diagnosis occurs, patients are treated, right? So once they're treated, survival changes. The survival curve essentially shifts, right? So we need to have separate models for survival and for tumor progression. That is just one thing that I want to mention. Yeah, so again, so these are the key risk factors that we found in the Indian context, specifically actually a study conducted in New Delhi, which found that BMI, marital status, educational status, occupational status, and the number of breastfeeding years are key factors, right? So BMI, I think, is associated, increased BMI is associated with multiple cancers, increased risk of multiple cancers. So that's not a surprising factor, but marital status and educational status were actually somewhat surprising risk factors. And the authors of the study also, which was conducted in 2009, also I think in RML hospital, if I remember correctly, they also actually comment on this, that they don't fully understand why this is the case. Now, if you want to see how it affects it exactly, I can actually just quickly shift to the paper itself. So we have that here. Yeah, so you can actually see that for patient, for people living with their spouses, the risk is actually lower, and again for people with who are employed, the risk is lower. As to why that is the case, it's not very clear. There could be issues around, I think, detection also, but it's actually not it's not immediately clear, and the authors also mentioned this. As for the number of breastfeeding years, that is actually quite straightforward. It is well known that parity, which is the number of children that the person has birthed, is actually inversely correlated with the risk of developing breast cancer, right, in women. So, so that is a well known, and the idea is that this is the number of breastfeeding years is basically a proxy for parity. Okay, so so once we, using the information in this published study, we were actually able to, and with some calibration, we were actually able to estimate what the age adjusted sort of in this time. The cases people have taken, especially in the US context, for example, which has one of the best models that are out there. Previous researchers have actually directly used models that actually predict, based on certain risk factor characteristics, what the possibilities are. So in our case, we use a slightly different approach. We actually calculate age adjusted ratios, age adjusted risk, the risk of developing cancer per 100,000 people based on odds ratios from a published study. So it's a slightly different approach. It's in some sense actually easier to do, although it did require a little bit of calibration. Okay, so once we model incidence, we actually then go into tumor growth, right? So now here, what we did was we actually did not use for modeling the growth of the tumor. That is, we use standard clinical information, right? So this equation is called as the Gompertz growth equation, which was published sometime around 1988 or so. You can see that here. And using this information, we actually model the growth of the tumor, right? And there is a little bit of adjustment associated with age done here. You can see that here, because breast cancer and a lot of cancers in general are more aggressive in younger people when they're incident in younger people, although the probability of them being incident in younger people is lower. They're more aggressive in younger people than in older people. So there's a little bit of adjustment that is done here. And then what we do is we actually calculate the volume of the tumor as it sort of grows with time, right? And we use that to figure out what the stage of the disease is. So we have these probabilities from from clinical studies that basically say, okay, what is the probability of the tumor being in the local stage, given that the volume of the disease is V, right? At time t is V. So this is an existing model that we use, okay? Clinical model that we use. Now, Then what we do is now we actually use data that is specific to India. So we know that how the tumor grows. Once we know that how the tumor grows with time, once we have this, we need to figure out at what point people are going to get diagnosed, right? So in the Indian context, what we find is that about 30% of people get diagnosed in the local stage, in the early stage. About 60% of people get diagnosed in the later stage, and about I think about 57% actually the number is, and about 10% or so get diagnosed in the distant stages, right? So in the very advanced stages. So what we want to do is to actually increase the number of people, is to find a screening policy that increases the number of people who are diagnosed in the local stages. That is, of course, what we want to do. Okay. So in order to do that, what we do is we use data about the stages that people are diagnosed in the Indian context from National Cancer Surveillance Projects. Actually, it's called as a cancer registry program that is available. It's run by pretty much every country. In India, it started somewhat late, but it's now, I think, going on pretty well. It's maintained, I think, largely by different places across India. Actually. So in Bangalore, there'll be an institute that has maintains a registry for, it maintains data about people who undergo a particular type of cancer in that region. Chennai will have one, Bombay will have one, Delhi will have one, and so on. Kolkata will have one, and so on, right? And then the National Cancer Registry Program actually integrates data from all these different sites and then publishes a report almost every year, if I remember correctly, or every 4 years or something like that. So I don't remember the exact interval between publication of these reports. Okay, so we use data from these reports to actually calculate then when the annual probability of diagnosis for a patient in a given stage. Okay, so for that, what we need is basically we need the annual probability of diagnosis. So these A's, right? So the AL, AR, and the AD. So AL is the probability of annual probability of diagnosis in the local stage. AR is the annual probability of diagnosis in the regional stage, and so on. So for that, what we have is PL that we have from the existing data, and what we don't have are the TLs. So once we have PL and TL, we can actually calculate AL, for example, from this equation and so on. And these are conditional properties. That's why you have the this is the probability of being diagnosed in the regional stage, given that one is not diagnosed in the local stage and so on, right? So in order to estimate the TLs, what we did is we use these probabilities and conduct a small Monte Carlo simulation to figure out what is the amount of time that somebody would spend in local without treatment, what is the amount of time that somebody would spend in region without treatment, and what is the amount of time that somebody would spend in the distant stage without treatment, right? Because the question is, okay, why didn't we escape this from literature? The reason is because once somebody is diagnosed, it is unethical to not treat them, right? So there is very little data that is available, and what data there is actually from the 1920s, 1930s, and so on. Actually, for the diagnosis, for the amount of time that somebody spends in these stages without treatment, and so we have to basically use this way to estimate the TL, the T values, right? So once we get this, although we were able to find one estimate for TD, but we needed to still estimate TL and TL. So once we get this, we are able to calculate AL, AR, and AD, right? Okay, so now we know when somebody is going to get diagnosed. We know incidence, we know tumor growth, we now know diagnosis as well, and we know staging as well, right? So using these equations. So once we have this, we actually now need to figure out, once somebody is diagnosed, what is the how does the survival actually go, right? So to our knowledge, there is only a single study that actually has published a survival curve for actually breast cancer patients in India. It was actually conducted way back in 1997. It actually uses, the study was published in 97, but it actually uses data from 1982 through 1989, right? So this is published by researchers from the National Cancer Institute from the Cancer Institute in Chennai, actually, right? So, so it was published by, there's a group actually that publishes extensively from there, and so they published it. Only study till date, which is pretty surprising. Which is pretty surprising. There is a lot of data around risk factors associated with survival, but there isn't actually one single. So if you look at, for example, the US and a lot of other countries, you will actually find a lot of data around survival based on various risk factors, actually, even based on, for example, actionable mutations and all sorts of different things. But that data is actually not available in the Indian context, and that's why we had to use this single survival curve that was actually published, and then based on the published hazard ratios for survival. So basically, there is a so what this says, for example, if you look at this figure, it says that people between the ages of 55 and 64 have a faster rate of progression. So they have the hazard ratio is actually greater than 1, which essentially implies that the chances of survival are actually lower, right, in some sense. So that's what. So using this, we actually had to generate survival curves based on based on age, right? So, for example, if a patient was diagnosed between age 55 and 64 in a particular stage, then we had to generate a survival curve that was specific to that person, and that's what we've done. We developed a methodology for doing that using that single survival curve and using the Cox proportional hazards model. Right? So, using this, we were able to generate and a little bit of a little bit of mathematical manipulation. We were able to generate these personalized survival curves based on a person's age and stage at diagnosis. Okay, so that's what is here. I'm not going to spend too much time on this. And these are the calibration results, right? So so typically when one develops a model such as this, the most important thing is actually calibrate, especially for clinical, so simulation models in general, of course, but in particular, if you're actually modeling some clinical process, such as, for example, the growth of a tumor, which is actually a physiological process, or if you're, for example, modeling, for example, treatment after if you're modeling survival after diagnosis of cancer, for example, that's a clinical process that you're modeling. Then, of course, you need to sort of validate it, right? So that is very important, and that's what we do here. So, so we have this is the calibration for the incidence, right? So we actually had to derive odds ratios for various risk factors that actually matched that were calibrated to the proportion of people who developed cancer with these risk factors from the published literature, right? So that's what we see here. And as you can see, for example, the proportion of people with a BMI less than 18.5 and who developed breast cancer was around 7% as observed in the literature. And what we got was around 6.76%, right? And we basically varied these, we calibrated these parameters in order to achieve this validation of the model. So similarly, you can see that the calibration target is about 29% of people who were supposed to get diagnosed in the local stage. We have around 30.24%, right? And so on. So similarly, we also had to we also had to calibrate the survival outcomes from the model as well. So one issue here that we had was that the data that we used for survival is actually pretty outdated. So you can see that it's actually between 1982 to 99, right? So these figures are from this paper from Gajalakshmi and colleagues published in 1997. Now, obviously, the treatment of cancer has improved significantly and survival has also improved significantly since then, right? So earlier in India also, for example, around this time, it was around 47.5% actually, the median 5-year survival for breast cancer, right? And now it is 66% on average. And as I said, in many, if you look at in certain urban areas, among certain socioeconomic classes of people, the survival is actually around the order of 90%, 94% as well for breast cancer, the 5-year survival, right? So, so the question is, okay, we've used this data, it's clearly outdated. How do we actually fix this? Right. So the way we did that was again through some mathematical manipulation. We were able to do that. And in the interest of time, I'm not going to sort of go into that. So people who are interested, they can of course refer to the paper or they can just contact me. And we were able to do this, and we were actually able to. So we had to calibrate the hazard ratios associated with each of these age groups as well as the cancer stage, and we were actually able to achieve, if you look at the overall survival outcome, the median 5-year survival that we get from the model, that is almost exactly equal to what we see, for example, in the in the literature, right? Which is around 66.1%, and what we get is 66.2%. So now we have a model of breast cancer incidence, progression, and diagnosis and survival that is actually reasonably well calibrated to clinical data that is out there. And now the idea is, of course, we can use this to do various things. We can use this to figure out, we can use this to figure out how to find the optimal screening. What should be the optimal screening interval, right, for the general population, as well as based on these incidence risk factors. So, for example, we can figure out in general, what should be this optimal screening interval for women in general in the Indian context? We can also figure out, okay, if somebody is at an increased risk of developing breast cancer because of, say, family history, or for example, uh, because, for example, of increased BMI or whatever, we can actually figure out that, okay, they should be screened more often, for example, right? So that is something that we've already done. We're working on a journal paper with those results. I'm not showing that because that is sort of, still, we're still writing the paper, but that is something that can be done. So next, what we want to do is to use the same paper to actually do, is use the same model, of course, to actually evaluate treatments, right? Different types of treatments, as well as we also want to look at screening for mutations. Now, not all breast cancers are the same. Certain breast cancers, in certain people, they have certain mutations that actually that are called as actionable mutations, and that can be there are treatments that are targeted specifically at that at cancers with those mutations actually. So that is what is seen. That is what is called as precision oncology or precision medicine these days, where based on the genetic profile of the cancer, you can actually have there are certain genetic profiles for which treatments are available. It's still not as precise as the name implies in some sense, but it's definitely better. And in fact, you have, in general, the standard approach for treating cancer is one of three modalities, right? So you have chemotherapy, you have surgery, and you have, of course, radiation, right? So, or a combination of all of these. But the thing with chemotherapy, the standard chemotherapy that is given is essentially it has a lot of toxicity, right? But that is not the case with some of these with these precision therapies. So what are called as immunotherapies, or they're called as the other types of therapies, the checkpoint inhibitors and so on, actually immune checkpoint inhibitors and so on. So these types of therapies, the advantage is that the toxicities are significantly lower and they're also a little bit more effective. Okay? So we want to actually model, okay, what is the optimal screening strategy for these mutations, right? So based on the prevalence of these mutations in the Indian context. So that is also something that we want to do. Okay. Yeah, so that's what I wanted to talk about. I think I've gone way over the time limit, but I hope that was not entirely uninteresting. Yeah, questions at this point? No questions at all? So, I mean, the implication from a public systems perspective, I think, should be fairly obvious for this. It's basically the idea is this can actually inform, it can inform policy around optimal screening intervals for women. It can, of course, and the model, of course, itself can be used for various other uh, 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 purposes, right? Like we talked about, for evaluating the cost effectiveness of treatments, for evaluating the cost effectiveness of screening for actionable mutations, new diagnostic technologies, all sorts of things. So that is the advantage of developing a model such as this. And this is exactly what I meant, where we wanted to develop a computational tool that can then be used for various types of analyses, actually, in this particular disease and area.
I think Meenakshi ma'am has a question.
Sure.
Mansi, I don't have a question.
Oh, sorry, I saw your hand raised.
Not a question, just a conversation with Dr. Ramamohan. Good afternoon, and I'm really delighted to see this kind of a work coming from our lab. And I'm sure there are no doubts about the applicability of this work. And I wish you all the best for the kind of future work initiatives also which you have suggested. One thing which I was like, I in fact want to know that
Sure.
if you look at this model, this is basically kind of a model in terms of an optimization problem only. We talk about machine maintenance. We say that we predict the behavior, and based on that, we try to optimize. Over maintenance is also bad, and in a way, less maintenance is also bad. So let's have an optimum duration during which the screening has to be done.
Yeah.
So
absolutely.
what I'm actually looking forward to is what is the new thing that we are referring to when we say that we are doing it in an Indian context? Is it just the data set, or is it there's something peculiar about the Indian population which we have tried to model in this problem?
See, I think the key thing is that's one of the things that I sort of want to we wanted to address right from the beginning, right? So when we do this sort of work, and I can tell you that from experience that if you develop a model and you say, okay, this is just using Indian data, and then you, for example, send it to a place like WinterSim or to any other standard OR journal, it's not going to fly. So they also want some methodological uh, contribution that can be generalized to other contexts as well, right? So of course the data is specific. Of course, when you do this sort of work, we definitely want to use Indian data. There is absolutely no doubt, right? Because of the differences as I talked about, right? So in the West, for example, there's a paper that we took a little bit of inspiration from for this type of work. It's a paper that was developed in the Indian context by Julie Ivy's group, actually, in North Carolina State University. Excellent work. I recommend reading those papers, actually. So they're great papers. But we also thought a lot of the things that they'd done were somewhat unnecessary, methodologically. They were, I think, some things were unnecessarily complicated. Some things they did differently because they had very different local data. I'll give you an example, right? So if you, for example, go here, let's see, let's come to staging and diagnosis in particular. Survival also, they did something very different. What they did in staging and diagnosis is actually, if you come to this equation here, right? So one question is, so this B is essentially the B that you see here, the tumor growth rate, that is actually a random variable. And what they did was, in order to assign the stage of the disease, right? They had information regarding the size of the tumor among US patients at symptomatic diagnosis and at diagnosis using screening methods, right? So normally they knew, okay, that when it is detected, this is the size of the tumor. And once they did this, once they had that, they actually back calculated stage from that size using these equations. So to us, actually, that seemed completely unnecessary because we said, okay, you already have these equations that actually do that actually give you the stage based on the volume. You also have equations that actually model growth. So we said, okay, and it is far more reliable instead. And the data, and in the Indian context, data around the stage of diagnosis is far more reliable than tumor size, because tumor size is not reported on at all in the Indian context, actually, right? And even if it is, for example, that is in some sense also, it's also subject to a lot more variation. So what is actually more relevant from a public health standpoint is, in some sense, the stage in which it is diagnosed, and the proportion of people who are diagnosed in different stages. So we said, okay, you know what, let's change our methodology then to make use of the data that we have in the Indian context. And this is likely to be also relevant to a lot of other countries, developing countries in particular, where you're likely to have cross-sectional studies, right? So what are called as cross-sectional studies in the sort of medical context, which basically take a snapshot of the current clinical scenario associated with the disease and then publish information regarding that, as opposed to, for example, longitudinal studies where you actually talk about a study that has looked at the evolution of some clinical scenario or a public health scenario over time, right? So you have it's in the Indian context and in a lot of developing countries, cross-sectional studies, for obvious reasons, due to funding and all of those things, are much easier to conduct and to publish, right? That's changing now. We have disease surveillance programs and all those things that are happening. But in general, you'll find a lot of cross-sectional information in the Indian context. So the question is, okay, how can you change your methodology to fit the availability of that sort of data, right? So if you ask what is new, it is, for example, the change in the methodology that we implemented. We used this information. We used this information, which is physiological information, with what is available, for example, in the Indian context from cross-sectional studies, right? So as opposed to what has been done earlier. Same thing is what we've done in the case of survival as well. Now, if you look at a lot of, for example, OECD countries, in particular, actually countries with, like for example, the US or the UK or Scandinavian countries and so on, they will have actually survival curves that are specific to each of these age groups that are published. That is actually clinically collected, right?
Correct.
In the Indian context, we don't have that. We only have, so far as this has been a single, because again, this is a longitudinal study, right? So it's not so easy to, it has traditionally not so easy, it has not been so easy to conduct. Now, I think, again, we have more studies coming out like this.
Okay.
So again, we change our methodology to basically fit this. So methodologically, we have done something that is actually new to fit the data availability situation.
Mhm.
I hope that
Yeah,
answers your
it's
question.
clear. And in fact, we can have a comparison of how continent-wise, or maybe based on the stage of the country, how these models vary, given the kind of explanation that you have given. It will also give a proper kind of a representation of our country or maybe our subcontinent with respect to the rest of the world. So yeah, I must congratulate you and compliment you for this nice set of work being done. Thank you.
One other thing I'd just like to mention is, because we're on the subject, is it's not, of course, I'm not presented this here because that work has not yet been published, but we actually have those results, right? So around the optimization part as well, where we applied what are called as ranking and selection simulation optimization techniques to actually figure the optimal staining interval using the simulation, right?
Okay.
And even that, again, it has not been done in this context. Second, it has also the way we've applied it as well, where we actually use this health economic quantity called as a net monetary benefit associated with a particular health intervention. We've actually optimized around that. That essentially becomes an objective function. So, so that is also something that is new. So yeah.
Okay.
Any other questions?
Okay, so Mansi, unfortunately, I have a hard stop at 6. So if there are no other questions, I will actually conclude the talk.
Yes, sir. So thank you again, Professor Ramamohan, for the interesting presentation. Thank you everyone for attending. I just request that the people who received the mail regarding the AGM to please stay back.
Thank you.
Thank you.